Okay. So this month's webinar is on the topic adaptable, subtitle Designed to Move, with me, myself, and I, Dr. Michael Maxwell. Sorry, I'm going to be distracted probably by letting a few people in here, so I apologize for that. So who am I? First and probably foremost, I am an educator of patients, but also I have a long history being heavily involved in the postgraduate education of chiropractors, physiotherapists, massage therapists, and other allied MSK professionals. More recently, I've become a teacher and instructor for Michael Shacklock. In fact, Canada's first international instructor for Michael Shacklock, teaching his courses on clinical neurodynamics. Michael Shacklock is one of the world's foremost experts in the area of neurodynamics, which is the study of the peripheral nervous system and how it functions. Peripheral nervous system, for example, being your sciatic nerve, which most people have heard of. I am also an instructor, Canada's only instructor for the famed and highly reputable Prague School of Rehabilitation, teaching a series of courses under the title Dynamic Neuromuscular Stabilization. I am a personal trainer, a coach, and kinesiologist by training. That is my original background. So I became a personal trainer when I was around 16 years old, and had early mentorship with a kinesiologist, and that really formed, largely the rest of my career in the direction that I took. I've also been a lifelong student. I'm passionate about learning, as you've probably gotten from the prior points I've mentioned, but always learning. And one of the things that we're very blessed with in clinical practice is to learn from the patients that present to us, both with the conditions and the factors that come with them, but also the humans that come into our office, which we're so fortunate to work with. I am a patient as well. Yes, I do have my own injuries. And when I was fairly young, I had a fairly severe lumbar disc herniation with what's called a radiculopathy, which is a specific nerve injury that affected my sciatic nerve. And that took me about a year to recover from. And in the process of recovering from that, I was exposed to many practitioners, all of who did a very good job, but none of which provided a complete job. Some people did a great job providing, for example, chiropractic manipulation. Another practitioner did a great job doing active release technique, and another practitioner did a great job with rehabilitation. And I always thought to myself, wow, it would have been really great if I had been able to see someone who would have been able to package all of that together in the beginning, because there were many plateaus that I hit along my recovery, which if you've ever been injured, that can be quite frustrating. So my experience as a patient forms a lot of who I am today as a chiropractor. And I'm truly fortunate to be in a profession in which we get to help the public. Total Body Health is the clinic that I work at. I'm one of the partners in Total Body Health, and our model of care is perhaps a little bit different than the typical. We have what I would call a movement-based approach to chiropractic, where our primary goals and outcomes surround the ability for patients to move better. And we believe that when people move better, they also feel better and perform better. And perform better perhaps has a connotation that for some people, perhaps it excludes them, or they feel that it excludes them, but in reality, it does not. In our view, every human performs in their outright through the activities that they perform in their daily living. If you're a great grandmother, we want you to be able to perform by continuing with your landscaping and gardening activities that you so much enjoy, or picking up and playing with your great grandchildren. So everyone on this planet performs in some regard, not just elite athletes. So that's kind of who we are, and that's who I am. So let's jump into today's topic. So I'm going to go through a series of tissues in our body that adapt, and adapt in very specific ways in response to movement, exercise, and load. One of them being bone. So in this image, you're seeing a series of cross sections of a bone. From the left being a healthy, strong bone, where you see very tight, what we call trabeculae, those little kind of honeycomb looking connections and spaces in between them are called trabeculae. And those bridges create the strength or the structural integrity of the bone. And as you see the transition going from the left to right, you see that the size of the spaces gets much, much bigger, and the number of trabeculae get a lot fewer. And that is the progression into what is called osteoporosis. Now, somewhere in that middle there, that would be called osteopenia, which would be a loss of bone mass and integrity to the bone structure, but not to the extent that would be diagnosed as osteoporosis, but nonetheless the progression toward it. So this is another image where you can see again on the left, this is a microscopic view of bone, where you see on the left a very tight trabeculae, honeycomb appearance to the bone. And then on the right, you see this kind of large vacuoles or spaces in between the trabeculae, and even some breaks or loss of continuity of them. Again, that is a sign of osteoporosis, or the loss of bone mass. So there are some general principles as it pertains to maintaining bone density or bone mass. Nutrition, obviously a big one. We need to provide the necessary prerequisites or building blocks to our bones, calcium, magnesium, zinc, etc. Exercise is all important, and I feel often underemphasized in the medical community, perhaps not amongst intellectual conversations, but certainly patients that I've seen who have been diagnosed with osteoporosis often aren't well advised on the role that weight bearing and strength training exercise plays in maintaining or even building bone mineral density. Habits can have a powerful influence. Both alcohol and smoking diminish bone mineral density or bone mass. And then supplements are helpful, but they are intended to complement a healthy lifestyle, which means obviously exercise and nutrition. So here's the thing. Only bone that experiences mechanical load will get stronger. So some individuals are perhaps led to believe that if they take calcium and magnesium, or if they take calcium, magnesium, and perhaps a prescription medication, that will necessarily improve or create the optimum environment for their bones. And the reality is that just simply isn't true. The only way that our bones get stronger is through mechanical load. And the reason why that is because of this fancy thing called mechanotransduction, which is simply the transfer of mechanical force that is then transduced into a cellular response that results in the laying down of the appropriate collagen, which is a fiber type material that creates like the twine of the rope, and the minerals in between it, which create the strength within bones. So when we load our bones beyond the degree to which they are accustomed to, there is a transfer of this mechanical tension or force into the cell via these fibers that you see within it. That information then goes right into the DNA of your cell, and the expression of the genes within that DNA then results in the laying down of the appropriate bone, or I should say minerals and connective tissue to strengthen and support the bones. So when we exercise, every single exercise has the opportunity to load bones in a very specific way. So I asked Jordan here, I said, do you feel the mechanotransduction? It's right here. And she says, yeah, my chiropractor is a little weird. Anyway, so here's the thing. Activities of daily living are insufficient. They are not sufficient to provide the degree of mechanical loading that improve bone mineral density. Walking is insufficient. A lot of my patients, of course, before I well informed them, were under the impression that walking was in a standalone, the only form of exercise that was necessary to maintain good health. They felt like that was sufficient to load their bones because it's weight bearing. Well, I'm sorry to tell you that that is simply not true. Walking is neither strength training nor sufficient to load your bones to get them stronger. Bone mass can be significantly increased, however, by a strength regimen or strength training regimen that uses high load, low repetitions. So when we say high load, low repetitions, what we mean is that the load is high enough that you simply can't complete many repetitions. Now, an endurance regimen that uses a low load and high repetitions is not sufficient to load your bones to build strength. Now, one of the concerns with this is in osteoporosis. There's a fear that if we load our bones too much, we might injure them. But lifting heavy weights under supervision has been shown to improve bone density in people with osteoporosis. You can lift heavy if you have osteoporosis. It's been proven to be safe that in a supervised program, even seniors or geriatrics can perform, for example, a powerlifting routine, as this woman is doing here, and thereby loading her bones, all of them, everything from her feet through her legs to her spine and her shoulder girdle and her hands. That load is going to improve her bone mineral density. Now, we never see osteopenia or osteoporosis to the exclusion of sarcopenia. This is often, I feel, a very missed conversation with patients. Sarcopenia is a word that implies sarco is the building block of individual fibers of a muscle. So sarco implies muscle. So sarcopenia means that you are losing or have lost muscle mass. And so what I'm saying here is that in order to build bone mineral density, you must load your bones through activity of the muscles. So when we see people with osteopenia or osteoporosis, virtually always, outside of there being a metabolic condition, some kind of a nutritional deficiency, it is associated with the loss of muscle mass as well. And a lot of people don't necessarily notice that they've lost muscle because it happens so gradually and slowly over the years. So now the next topic is muscle. So Muscle, if you've worked with us at all, you'll know that we're pretty fascinated with muscle and the way that we control our bodies. So I've got a series of quotes here that I want to share you from a research study, which says, one of the most striking effects of age is the involuntary loss of muscle mass, strength, and function, termed sarcopenia. Muscle mass decreases approximately 3 to 8% per decade after the age of 30. And this rate of decline is even higher after the age of 60. Now, I want to key in on that word involuntary. Most people do not recognize that they're losing muscle mass each year as they age. One, because it happens so slowly, they don't necessarily notice it. Two, because often when you lose muscle mass, you gain fat mass, so they don't necessarily get smaller and they don't necessarily change weight either. So many people do not recognize that they're losing muscle mass until it reaches a certain threshold in which they notice that, for example, they can't walk upstairs very well, or they can't get up off the floor very well. And guess what? By the time that happens, it's been going on for a very long time. So this involuntary loss of muscle mass, strength, and function is a fundamental cause and contributor of disability in older people. This is because sarcopenia increases the risks of falls and vulnerability to injury, and consequently can lead to functional dependence and disability. Now, this brings into another topic, which I'll take a brief foray into. A lot of people are concerned about fracture risk and falling, so they work on their balance. But the thing is that a lot of people have compromised balance because they've lost their ability to stabilize, because they can't create the necessary stiffness in their body. And you create stiffness within your body, or functional stiffness in your body, through muscular contraction. So when we lose muscle mass, when we lose muscle strength and power, we very often lose the ability to create the necessary stiffness that keeps us upright. So our training for balance always includes strength training, and sometimes that is completely sufficient to resolve a balance dysfunction. Now, a decrease in muscle mass is also accompanied by a progressive increase in fat mass, as I alluded to earlier, and consequently changes in body composition. This is associated with an increased incidence of insulin resistance in the elderly. So bone density decreases, joint stiffness increases, resulting often in a small reduction in stature, because we lose our postural uprighting abilities. And we lose our postural uprighting abilities, we start to slouch and we become kyphotic, or we get more rounded in our mid to upper back, and thereby we lose the height in our posture. The implications for a loss of muscle mass are, again, insulin resistance, which leads to type 2 diabetes, obesity, heart disease, and osteoporosis. Now, endurance and strength training adaptations not only contribute toward potential sporting activity excellence, which, again, don't think just sporting activity, but really whichever activity you choose to do, you can be excellent at by being stronger, by being fitter. But in most instances, when that fails to be the case, it contributes toward the delayed onset of age-related diseases. Or sorry, when you perform endurance and strength training activities, it delays the onset of age-related diseases. So this is an image of top left, a 40-year-old male triathlete. Right next to it on the top right, you see a 70-year-old male triathlete with a very similar muscle density, with a very similar muscle size and a very similar body composition. He has very little fat mass. Now below, you see a 70-year-old sedentary male. Now you might notice that the size of the thighs are pretty similar, but the composition is much, much different. So that lighter color material that you see on the outside, on the bottom, that is fat, that is adipose tissue. And the darker substance in the middle is muscle. And you can even see the quality of the muscle is very different in the sedentary male compared to the active counterparts above. And this is not an age-related condition. this is a really important concept to understand. A lot of people will come in and in the process of discussing a diagnosis, a lot of people will ask the question, oh, I must be getting old, or it's the consequence of getting old. And okay, yes, there are consequences of getting old, but a lot of times people come in with injuries or ailments that are not associated with age at all. They're associated with the loss of strength, with the loss of function associated with reduction of muscle mass, by virtue of not being able to, or not sufficiently loading their body throughout their lifetime. So how does this all happen? Endurance adaptations actually result in an improved efficiency of the mitochondria. So the mitochondria is essentially like the energy house, it's the furnace inside your cell that produces the energy for it to contract. In fact, every cell in your body uses a mitochondria to create energy to do the work that it needs to do to maintain you. So when we exercise, in specific, when we do endurance exercise, we improve our ability for that mitochondria to perform what's called mitochondrial respiration, which really isn't that much different than the respiration that you would think of, and the fact that it processes oxygen to create an energy unit that allows your muscles to perform work. Now, what this study is demonstrating or discussing is that there is a specific adaptation to specific forms of endurance exercise. So, for example, sprint interval training, that is high intensity training performed repetitively. A common example might be in a spin class where you perform high intensity intervals of sprints followed by rest, or if you were performing a 400-meter sprint and then you take a period of rest. Well, that sprint interval training improves the activity and efficiency of mitochondrial respiration. Likewise, high-intensity interval training, HIIT training as it's so called, promotes also increased mitochondrial respiration, but also improves or increases mitochondrial content. Long, slow distance training also improves the volume of mitochondria within the cell. That literally means that you are growing more mitochondria within your cells, which obviously is going to improve the ability to produce energy for the things that you want to do. Now, mitochondrial biogenesis is a term that implies that when we exercise in an endurance way, we get an increased number of mitochondria. We have an enhanced function of the mitochondria, and that allows us to produce the energy that we need to perform the activities that we want for longer, without becoming fatigued. The other really interesting thing that happens when we exercise in an endurance capacity is that we actually grow more capillaries. So what you're seeing on the right top side is you're seeing a muscle with a limited capillary density. Obviously, that's going to have an effect on how much oxygen can be delivered into that tissue. On the bottom, you see this well-trained or normal muscle where you have capillary density that's much higher, and obviously that can provide much more oxygen to the muscle. The body is pretty amazing, like both in the case of bone and muscle. When you don't use it, your body just decides that, hey, like I might as well use this energy somewhere else. If he's not going to use this muscle, I might as well just prune off the connective tissue within it, reduce the mass of it, and even reduce the number of capillaries that penetrate into it. On the flip side of that, when you create a demand on your body, whether that's bone or muscle, your body intelligently adapts to that by creating stronger bones and larger, more efficient muscles. So there are also strength adaptations, which are achieved by what I alluded to earlier, which is heavier loads. And those strength adaptations are both a neural adaptation and a muscle mass adaptation. So you can see the top line of the graphs showing a strength change, which is a result of your nervous system becoming more efficient to activate what we call motor units, which is where your nerves enter into your muscle and they branch on to specific fibers within that muscle. That's called a motor unit. And when we become more efficient at activating those fibers, we therefore can use the full breadth of our muscles, and that makes us stronger. Now, we also, a slower adaptation would be an improvement in muscle mass, where we literally build bigger muscles. This seems so obvious to people because we see bodybuilders, people that strength train, but if you really think about the cellular and DNA or genetic adaptations that occur to make this happen, it's pretty fascinating. And again, it happens through the adaptation of these fibers within the muscle, and it does it through the exact same mechanism, which is called mechanotransduction, the translation of mechanical force into cellular activity, which results in the laying down of proteins to strengthen a muscle. Now, all of these adaptations can occur independent of your age. People who are seniors or even geriatrics can build bigger muscles. They can improve mitochondrial respiration. They can improve the number of mitochondria within their cells. They can even improve the number of capillaries that penetrate into them to become stronger, more efficient humans, which is pretty freaking cool. Regardless of our age, the adaptations to strength training or endurance training are pretty similar. So exercise improves metabolic control, both via increasing muscle glucose, that's sugar, uptake during muscle contractions by insulin-independent mechanisms, meaning not using insulin, and also by increasing skeletal muscle insulin sensitivity. Now, the reason why this is important is because insulin resistance is a precondition to diabetes. So when we exercise, we actually improve the sensitivity of our muscles and the cells within it to uptake sugar. And that was one of the hallmarks of diabetes, is that you become insulin resistant. In other words, the cells in your tissues do not absorb glucose as they normally should. So insulin resistance and metabolic syndrome are powerful risk factors for the development of cardiovascular disease and type 2 diabetes. Okay, so joint health and articular cartilage. So there are a few myths that are rather prevalent in the general public on joint health and activity or exercise. But one of those myths is that running damages the knees. This is simply not true. Running applies obviously a mechanical force to your knees, but interestingly enough, your cartilage is very well designed to handle the mechanical force. In fact, it's rather necessary for its maintenance. So in this study, they showed that a significant increase in the quality of knee cartilage occurred after a 10-week running program that built up progressively. So even in adults, the quality of the cartilage can be changed. A gradually built up running scheme exerts a chondroprotective effect, meaning protects the cartilage within your joints on the knee when compared to a sedentary lifestyle. In other words, running is better and more protective on your cartilage than being sedentary. Now, a moderate running scheme might be a valuable proposition in osteoarthritis prevention strategies, which is certainly counter to many common perceptions out there that if we run or perform these impact activities where we're pounding on the pavement, as people will say, that we cause osteoarthritis. And like I said, that's just simply not true. Now, the other myth of joint health is that if I've got arthritis or as I'm getting older, I should take it easy. This is also not true. Inactivity reduces cartilage thickness and function. Inactivity and obesity cause and worsen arthritis. In young, healthy adults, exercise appears to exert a beneficial influence on cartilage. With increasing age, protective effects persist in the case of light to moderate exercise in those individuals without radiographic signs of osteoarthritis or at risk. Let me get to the explanation of what I'm trying to say here in a moment, but let me read this through. In the case of a pre-existing internal knee derangement, in other words, if you had, for example, a meniscus injury, if you had evidence of a bone marrow lesion or a cartilage defect, prolonged and excessive physical activity is suggested to accelerate the deterioration of joint structures. So listen, moderate activities in these folks is still super important. But when you do have signs of impaired joint health, it is important to manage the loads that go through your joints and not be too hard on them. But that does not mean rest. We need that light to moderate exercise, even in osteoarthritis, to maintain the structures within that joint. In the short term, pain can be reduced by avoiding physical activity. In the long term, however, low activity levels will result in a deterioration of physical condition, especially in muscle weakness. Now, muscles support your joints. Without adequate strength and stability that's provided by the muscular system, you overload your cartilage. So rest simply is not an appropriate solution for impaired joint health or osteoarthritis. A balanced, well-designed program that loads your joints and your bones and your muscles is the only way to go. Okay, another topic, exercise in the immune system. So physical exercise acts as a modulator of the immune system. Acute exercise is an immune system adjuvant, meaning it promotes immune system activity that improves the defense activity and metabolic health. There is a clear inverse relationship between moderate exercise training and illness risk. In other words, when you perform moderate exercise, you reduce the likelihood that you will get ill. Exercise training has an anti-inflammatory influence mediated through multiple pathways. Illness risk is increased in athletes during periods of intensified training and competition. Increased carbohydrate and polyphenol intake is an effective nutritional strategy for immune support. Now, this probably doesn't apply to the average Joe, but what this is saying is that when you have an elite athlete who pushes their body to the absolute max, when they're in that kind of supra threshold training, where they're really kind of pushing their volumes and intensities, they are at slightly increased risk for immune system dysfunction and potential illness. But there is a mediator in that if their nutrition is really well dialed in, it can be protective from this. Now, habitual exercise improves immune regulation and it delays the onset of age-related dysfunction of your immune system. Exercise lowers the incidence, intensity of symptoms, and mortality in viral infections observed in people who practice physical activity regularly. Now, footnote, if you look down on the bottom left, pertinent to our present situation, if you look at the reference, this is actually a study that was in relationship to COVID-19. So although exercise improves your immune system function in relationship to any viral infection, this particular study was talking about the beneficial effects of exercise as it relates to protection from COVID-19. So via immune system, inflammatory, hormonal, and metabolic mechanisms, exercise reduces the risk of several cancers by 20 to 50%. Now, there's many reasons why that happens, as you see above, but they are somewhat similar to the effects on reducing the risk for illness. Yeah, this is pretty profound. And, you know, a lot of people maybe become a little bit apathetic to cancer risk. You know, it's like everything is carcinogenic, so I'm just going to eat anything. Or, oh yeah, well, everything is carcinogenic. Why the heck would I worry about exercising? Well, I mean, I think it matters. I don't want to go down that way. I mean, I might still, but I wanted to reduce my risk the best I possibly can. And footnote to that is that exercise also has been shown to improve a person's ability to get through an already diagnosed cancer. How about the brain and mental health as it relates to exercise? So brain health decreases with age. And note, this is not saying mental health decreases with age, although that could be relevant. What it's saying here is brain health. So the tissue of your brain decreases with age, with the average brain shrinking, this is a little depressing, by approximately 5% per decade after the age of 40. Now, here's the thing. Significant increases in brain volume have been found as a function of fitness training for the older adults who participated in the aerobic fitness training. Now, if you had participated with in exercise throughout your life, there is a significant protective effect against that attrition that I was noting a moment ago. So in short, exercise gives you bigger brain parts. So there's also evidence to show that consistent evidence to show that exercise improves memory and cognition. It prevents or delays the loss of cognitive function with aging and reduces the risk for neurodegenerative diseases, which, for example, would be like Alzheimer's or dementia. That image, by the way, on the right is a picture of a normal brain in comparison to a brain with severe Alzheimer's. As you can see, there is significant atrophy of the brain that is on the right. And exercise has been shown to help prevent that. So there's large bodies of evidence that indicate that stress can activate an inflammatory response in the brain and the body. Here's the thing. In routine general practice, an estimated 70% of cases of mental health were primarily treated with antidepressants worldwide. And this particular study, these are not my words, this is a research study's words. This is worrisome as there is increasing evidence that antidepressants, while bringing about side effects, are ineffective in patients with mild to moderate depressive disorders, which are particularly common. Now, physical exercise has been shown to be an effective treatment for unipolar depression. Exercise has been shown to compare favorably to no intervention at all, and also favorably in comparison to usual care for depression. And usual care for depression is via a GP and typically antidepressant medication. Exercise is comparable to psychotherapy and antidepressants for depression. I personally feel that we should be coupling both exercise and psychotherapy, because I believe that counseling is very important to maybe get to some of the root causes of it. But I think antidepressants to the exclusion of counseling or psychology, which is called psychotherapy here, and exercise, I think is very inappropriate because the evidence just simply doesn't support that. Now, it says here, exercise could be a viable adjunct and augmentation to antidepressants for depression. I do think that they're understating this. I really think that the standard of care, in fact, if you look at care pathways for depression, step one in mild depression is actually lifestyle-based medicine, exercise, clinical counseling, things like that, not antidepressants. Antidepressants comes in actually at step two in the management of mild depression. And then again, exercise may serve as an alternative to established treatments. Okay, so this is kind of an interesting note. There has been shown to be a positive relationship between an acute phase systemic inflammatory response and recovery at 6 months. So let me contextualize this. This study was looking at those who suffered a low back injury. And what they showed was that those who had a more pronounced acute inflammatory response. In other words, the signs of inflammation in the body in response to the injury had a better recovery. So high inflammation was associated with good recovery. However, there's a footnote to this. Elevation of a specific kind of inflammation, which is called a tumor necrosis factor alpha, along with depressive symptoms, was associated with bad recovery. Now, we don't know why in these particular patients the TNF alpha was elevated, but we do know that it is common for TNF alpha to be elevated in depression. So it is possible that stress, the depression created a change in the systemic physiology, and that unfortunately led to bad recovery in these particular patients. So inflammation is actually a good thing for recovery. And specifically the acute phase inflammation that occurs when you're injured, not the chronic inflammation that is associated with perhaps depression or other systemic illnesses. So TNF what? So tumor necrosis factor. I won't spend too much time on this. I just felt like I needed to elaborate a little bit on this, but it is an inflammatory cytokine. Cytokine's like it's a protein molecular substance that circulates through your blood and helps regulate the immune system, but also is part of the inflammatory process. It has been implicated in a number of inflammatory conditions, like, for example, rheumatoid arthritis, ankylosing spondylitis, heart disease, depression, uterine fibroids, Alzheimer's. It is elevated in obesity. Why? Because adipose tissue, fat tissue, is essentially a good engine for inflammation. It's elevated by smoking. It's reduced by having healthy vitamin D levels. There are certain supplements such as curcumin, resveratrol, probiotics, et cetera, that can reduce tumor necrosis factor alpha. And exercise exerts part of its anti-inflammatory effects by, in fact, reducing tumor necrosis factor alpha. So in other words, if you have a healthy physiology, you exercise regularly, and then you get injured, it's very possible that that healthy physiology will help you recover better from that injury because of the reduced tumor necrosis factor alpha. So here's another study. Anti-inflammatory treatments, prolonged pain duration. I don't know if you're already going there in your mind, but when I said the acute inflammatory response is actually good for healing, good for recovery, maybe what you were thinking in your mind's eye is that, what about those anti-inflammatories like ibuprofen or Advil or Motrin? And taking those when we have an acute injury. Well, there is some decent research, a few studies now that have shown that there is a negative effect of anti-inflammatories on treatment for acute low back pain. So in this study, it showed that anti-inflammatory treatments are prolonged pain duration after a low back injury, and the use of anti-inflammatory drugs was associated with increased risk of persistent pain, suggesting that anti-inflammatory treatments might have negative effects on pain duration. So despite the analgesic efficacy, analgesic is pain relief. So despite the fact that these medications might provide pain relief at early time points, the management of acute inflammation may be counterproductive for long-term outcomes. So this is a quote from the researcher of one of these studies, who says the standard medical management for this type of pain turns out to be probably making matters worse, not better. I just talked a lot about how activity and exercise improves our physical health. So I think it's pertinent to highlight that despite the irrefutable benefits of exercise, only about 17.6% of Canadians attain guideline levels of physical activity. Now, not only is that the case, but you also have only about 15.8% of Canadian physicians providing patients with exercise prescriptions. Now, I could go on about how bad the medical profession is for doing this, but the reality is we're not that much better. There's been studies on chiropractors, even physiotherapists, massage therapists that show that we're also not that good at providing guideline level prescriptions for activity. Something that I think we do a pretty darn good job at Total Body Health, because we really try to think big picture. Now, listen, every cell in your body, the fiber of your being, is designed to move. It's designed to exercise. If there was a drug that could do all of what exercise can do, that had no negative side effects, would you take it? How much would you pay for that drug, right? A lot. You pay a lot. But nonetheless, we have only under 18% of Canadians performing physical activity at the recommended levels for optimum health. So that's something that I hope we as a collective community can change. Not just us, but I hope you guys here spread the good word about how important exercise is for us. Now, what are the activity guidelines or exercise guidelines? And this is pretty universal, internationally. These are the Canadian guidelines for physical activity, which says that we should have moderate to vigorous aerobic physical activities such as running or brisk walking, hiking, cycling at about 150 minutes per week at least. And also we should have muscle strengthening activities using our major muscle groups at least twice a week. We should also have several hours of light physical activities, including standing, walking, gardening, etc. So that 150 minutes is really specific to moderate to vigorous activity, and then 2 days of strength training. And then, yes, that's not it. We also should be active in other times of the day as well. There is substantial research to show that having prolonged sedentary behaviors through the day, for example, if you work an 8-hour day and you're sitting all day long for those 8 hours, we can't actually fully compensate for that sedentary behavior with exercise. So if we can limit that sedentary behavior with mini breaks throughout the day, so, going for a short walk at lunch, or I'll often advise my patients, hey, like every hour, just do 3 minutes of movement. So get up and do some squats, do some lunges, do a warrior pose, go up and down the stairs, just something to move your body and promote some circulation and activity. Now, sleep is also super important for health. Their recommendation is 7 to 9 hours of good quality sleep on a regular basis, with consistent bed and wake up times. And then it also says limit sedentary time to 8 hours or less, which includes no more than 3 hours of recreational screen time, and breaking up long periods of sitting as soon as possible, as I just alluded to. So you are adaptable. Well, we've got a little bit more. We would be remiss if we didn't talk specifically about exercise, activity, injury, and pain. So let me take a few moments to make a few notes on that, since that is kind of what we do at Total Body Health, is we rehabilitate people who are in pain or injured and try to bring them back to full vitality and full function, if not better. So pain, by the way, is the leading cause of disability and disease burden globally. Low back and neck pain have consistently been the leading cause of disability, as in top 10 leading cause of disability in Canada and globally. And the reality is we will all experience an injury or pain at some point in our lives. It is, in fact, a normal part of life to get injured at some point. No one gets through this life without getting injured at least once. And if they don't, man, they're pretty lucky. or they're just not doing much. Okay, so the question is, when we get injured, how will we respond? Thoughts, emotions, behaviors, and actions as we enter the rehabilitative or recovery process can have a huge bearing on our recovery. Mindfulness, our emotions can have a dramatic influence over pain. And we have the power through our thoughts and emotions to, in fact, amplify the intensity and unpleasantness of our pain. We also, however, have the ability through our thoughts and emotions to dampen the intensity and reduce the distress associated with our pain. So on the right here, you see specific parts of the brain that are activated in response to mindfulness meditation in individuals who are experiencing pain, and they show certain parts of the brain light up in response to this activity, and is associated with reduced intensity of their pain and the reduced unpleasantness of our pain. Here's the thing. Those lit up areas of the brain is activity that creates adaptation. So every thought that we have has the possibility, if repeated over time, to ingrain itself within our brain. Every emotion we have has the opportunity through repeated action to ingrain itself in our brain. In other words, what we do, we get better at, not just in our bones and our muscles and our cartilage and our joints, but our brain too. It's called neuroplasticity. The more we stress about our pain, the more emotional we get in response to our pain, or the more distressed we become, the more likely we are to activate the neural circuits that potentially promote a higher degree of pain, the unpleasantness of it, but also increase the likelihood of perhaps ongoing pain, which is the big thing that we want to avoid. Because as I said, listen, we get injured, that happens in life, but the key thing is how we respond it. So here's the thing. When we get injured, move the big rocks first. Find your foundations of health. So that means engaging in healthy physical activity in the context for the injury that you've experienced. That means having a healthy mindset. That means having a healthy social circle. I can't tell you how many times we get patients who come in with acute neck pain that are a result of stress. So that saying, the old saying of, hey, you're a pain in my neck, I'm pretty sure my mom and maybe my grandmother probably said that at some point to me. You're a pain in the neck, Michael. Yeah, I've heard that before. So here's the thing. That literally is the pain in the neck. So stress literally can cause pain in your neck. And when we're going through the recovery process, having healthy social interactions, having a healthy mind and regulating our emotions has a huge bearing on our overall health and inflammation within our body. And like I said, also addressing physical activity is important in the context of the injury that you've experienced. Now, a lot of people will come into the office. I recall a case a few years ago, tennis elbow. He had gone through a little bit of a bad stretch and gained a bunch of weight, goes into the gym, been working out for about 4 months, has lost a bunch of weight. He's feeling great. And then he gets this tennis elbow. It's quite sore, super inflamed. And the doctor's recommendation was, well, you're going to have to stop exercising. Of course, I don't know that the doctor meant stop exercising in total, but that was the message that the patient took away. So by the time I saw him, he had gained all that weight back. And then I asked him, I said, well, you still have legs. He kind of like stopped and paused. Oh yeah. Like he had every part of his body above his right elbow through his entire trunk, his left arm and his legs, to still move and exercise. And the amazing thing is that if you exercise your left arm when your right is injured, there is a neurological crossover that results in your right arm getting stronger. So training our uninjured side can actually improve the injury recovery process on the injured side, even when we can't load that area because it's still acutely injured. So there's a few steps that I encourage in the process of recovery. Number one is acceptance. Accept where you're at. When we fight reality, when we fight what is, which is I'm injured, it makes us more stressed. It makes us more anxious. It fuels poor decision-making. Sometimes it even fuels self-hate or self-loathing. So acceptance of where we're at and recognizing that we are injured and that this is going to be a process that we're just going to get through. Commitment to the process of recovery, and consultation. Get consultation with an experienced professional that can guide you in the process of diagnosis, which starts with a comprehensive, oh, geez, that was fast. Sorry. Let's try that again. Yeah, don't go in here. All right, apparently that slide had a transition that was unruly. The point there was that consultation starts with a comprehensive assessment, and that comprehensive assessment forms diagnosis, and that diagnosis creates the foundation or starting point for your recovery process. So the diagnosis has many, oh my goodness, I hope that doesn't happen throughout. Diagnosis has many parts. Number one is the tissue involved and the nature of its involvement. So for example, you might have a tendon injury. A tendinopathy doesn't usually mean a tendon is torn. It means that you have inflammation or sensitivity of a tendon in response to overloading. Bursitis or inflammation of a bursa, a ligament sprain, perhaps a disc injury like a disc herniation, or a nerve injury resulting from perhaps a compressed nerve, which sometimes we call a nerve entrapment injury. So these tissues that become injured all have inherent traits to them that allow us to determine what is suitable in the early recovery process and how to transition into recovery. So the next step is identifying the cause. So yeah, we got to know what is injured, but we also have to identify the cause. And listen, sometimes that's traumatic, but the reality is most patients that come into our office do not come into our office with pain or injury that results from a traumatic origin. In other words, like a fall, or a motor vehicle collision. Yes, we obviously see that, but most of the patients that we see in our clinic injure the lower back by tying up their shoes or performing repetitive movement. Or sometimes it results from weakness or imbalance or deconditioning. Sometimes there's an inflammatory origin to their injury, an inflammatory origin, for example, being a result of an inflammatory disorder, or perhaps just dysregulated inflammation in the body as a result of high stress, poor sleep, and poor nutrition. So part 3 of this is addressing contributing factors. So, okay, we've talked about causal or mechanisms for the injury to occur, but sometimes we have contributing factors that perhaps lead to the overstress of that knee. For example, poor hip stability or poor foot pronation in a knee injury. Or in a low back injury, it could be caused or associated with poor trunk stability. That's in I guess pop culture is called core stability or stability of your trunk, and what we call motor control dysfunction. Motor control meaning how your brain controls the muscles in your body and coordinates them together to keep your joints stable. So those can be contributing factors to an injury. So here's a big one, and we've kind of alluded to this already, perpetuating factors. So perpetuating factors are things that would elevate risk of chronic pain and persistent disability. And perpetuating factors tend to be things like fear avoidance. So being fearful of moving your back because you've injured it leads you to avoiding everything. And that actually can increase the probability of experiencing chronic pain. Now, we think that is in part due to increased stiffness in the tissues around the back, but perhaps largely as a result of a sensitization of your nervous system. As I said earlier, the more stressed and emotionally distressed you are when you're injured, the more likely you activate the neural circuits in your brain. And with practice, sometimes that can become a habit. So your brain actually gets really good at experiencing pain, because that is the mechanism by which we tend to avoid activities that cause stress on our bodies, which when you're out of the acute phase of an injury, we need to do that. We need to stress those tissues that were once injured to build them back up again. Catastrophization is similar, but slightly different. That is when we have an injury and it becomes a lot bigger in our mind's eye. High stress, social or emotional, sleep dysfunction can increase the risk for chronic pain, poor nutrition, passive coping. So when patients become reliant on passive therapies like massage or acupuncture or a chiropractic adjustment, that actually can increase the risk for chronic pain because they're not taking an active role in their recovery process. And that's incredibly important. Low self-efficacy. So when we don't have the belief that we can get better, or we don't have the self-affirming thoughts and opinions of ourselves to work through that process, it can increase our risk for chronic pain and sustained disability. Work demands and satisfaction can also play a role. So if we are in a position of employment where our employer is not very understanding of our injury and perhaps the temporary disability that we are in, that increases stress big time on people, and stress is not good for recovery. Job satisfaction also can be a source of stress, but it can also mean people aren't so keen to go back to that job. So perhaps they're maybe a little bit happier being injured than they are in the job that is resulting in some stress in their life. So in my humble opinion, chiropractors are probably the best positioned in our healthcare system to evaluate and diagnose musculoskeletal injuries, to triage those injuries to ensure that there isn't anything more sinister going on that maybe we need medical imaging for, like an MRI or an X-ray or a referral to a specialist. But this is our gig. Like, we take 4 years of specialized education in which we completely dedicate that time to understanding the human body, and specifically the musculoskeletal system, not just the backs, but the finger and the toe and the knee, and how to appropriately evaluate, diagnose, and help people along their recovery. Medical doctors just simply don't get that level of time and experience in that musculoskeletal specialty. So they're an essential part in the medical system, obviously, but when it comes to musculoskeletal injuries, there probably isn't anyone better positioned to evaluate and diagnose the characteristics of your injury than a chiropractor. So expectations. Listen, a lot of people come in and they're injured and they don't know, like they've never had an injury before, and they're thinking, this will be a 3-week thing, and then I'll just be fine. And that's not always the case. And I give the analogy of when an athlete experiences an ACL tear, which is a ligament in the knee, or even think of a severe ankle sprain. Those injuries are known to take 6 months at best, but more likely 12 months to fully recover from. And that doesn't mean that they have pain throughout that period of time. It doesn't mean that they still have pain at 3 months, but it means they're not recovered yet. They're not ready to return to their activity, whether it's a sport or otherwise, because they still have a level of dysfunction and disability as a result of the injury that they still need to build back up from. So listen, it takes time. And that acute phase response, where we have this acute inflammation or the swelling and the redness, sometimes the inability to move without significant discomfort, that is typically short-lived. Maybe 2-3 weeks should be. But beyond that 3 weeks, there's this extended period of time in which we need to rehabilitate our bodies to its full capacity. So there's a few steps I want you to consider in the recovery process. One is relative rest. So yeah, when we get injured, we should relatively rest the tissue that's been injured. And that knowledge of which tissue is injured helps guide that process, but it also guides an understanding of the positions, postures, and patterns of provocation, which are the positions, patterns, or patterns that would provoke or stress that tissue unduly, perhaps perpetuating the inflammatory response in that tissue or delaying the recovery process. But also it helps us guide understanding of relief positions. So what positions should we go in to get relief from, or what activities should we be doing that we can do to help the recovery process or reduce pain, inflammation, and swelling. So relative rest is an important first part of the process. And then step 2 is rehabilitation. And that is AKA recovery, reformation, reclamation, restoration, renewal, reconstruction, or reestablishment of fitness, of function, not just pain resolution, but the full renewal of function and abilities. Now, some people come to us with injuries that have been caused by the fact that they are already deconditioned, that they are already in a poor state of physical health. So in those instances, to me, renewal or recovery means going well beyond what the status quo was before they got injured, because that likely was the state that led to their injury to begin with. So very often we need to not just recover in the context of pain relief, but we also need to fully rehabilitate our functional abilities. Rehabilitation is specific to the needs. It's determined by the assessment, which we do to create the diagnosis. And briefly, a longitudinal assessment is much more informative than a snapshot assessment. I recently had a case where I evaluated a patient, and my ability to see that patient over 3 or 4 weeks significantly enhanced our understanding of the condition and allowed us to form an accurate diagnosis and therefore create the treatment plan that was ultimately necessary to get them better. I wish I had gotten to that conclusion in the first session, but that's not always possible. And in fact, the snapshot assessment that had performed by the prior specialist who assessed this patient was in fact incorrect. Very experienced and knowledgeable professional, but that snapshot, just like in my case, wasn't sufficient to determine the most accurate diagnosis and recovery process. And that brings me to layering. When we rehabilitate injuries, there is a layering response to the body. As you improve certain functions and capacities, we often uncover a new level of function that we can build on. And so each week we're looking to layer and progress on the week that is prior. And that means that you're better 6 weeks, you're better again at 12 weeks, you're better again at 6 months, and you're better again at 1 year. Why? Because you've continued the adaptation process through intelligent and well-informed exercise prescription, which helps build the body up, as I discussed in the earlier part of the presentation. Now, lastly, after we've rehabilitated the body to gain full function, and part of that process is a graded exposure. So very often, if a patient comes in and they have a low back injury secondary to a work-related stress, i.e. they have to bend over into an engine of a vehicle repeatedly throughout the day, and they have an injury where that's painful, well, they have to modify the activities temporarily while we rehabilitate the system, and then we slowly grade the exposure to that previously provocative activity to reduce sensitivity in the system and build the resilience in those tissues to well tolerate that load once again. So that is all for the presentation. I just want to remind you that you are adaptable.